Before we do start, quickly wanted to plug the Bridging the Gap conference, which we have here in sunny San Diego in July, which is a really unique meeting talking about surgeon health, surgeon experience, and trying to close some of the gaps in spine surgery. And if you have any interest in being in Southern California in July, please hit up the website. It's a great meeting. And thank you all for being at the West Coast Fellows Conference. This is actually our 26th iteration, continues to go strong. Very, very pleased to have somebody from the East Coast, my former home, New York, and Dr. Riew. And we're going to have Stephen, one of his former fellows, do a brief introduction.
Hey everybody. Sorry I'm on vacation, but could not miss the chance to introduce and listen to Dr. Riew. He doesn't really need much of an introduction. I had his assistant send me his CV, but it's like 78 pages long, so we're not going to go through it. He's probably the leading voice in cervical spine surgery, definitely the leading voice, and it's kind of comes down to, what would Dan do? Ultimately kind of wins the arguments. But he's a master technician, probably my biggest mentor through fellowship, and someone I still reach out to every single week about different cases. And I'll you guys are going to get a glimpse of kind of what my fellowship was like today, and how we don't know what we're looking at, and he'll let you know that. I think one of my favorite things in operating with him is, you do the dissection, you're doing the work while he's watching, and always tells you during the case that the spine is a midline structure, and that nothing will stress you out and make you feel more nervous while operating with him when he reminds you of that. So I'll let Dan take it over, and looking forward to what you have to teach us.
So Dr. Riew, stop sharing, and then you can go ahead and share your slides.
All right. Can you see that okay?
Yep, we're good to go.
All right, perfect. So I'm going to go very quickly, but the first, by the way, my disclosures. I guess I forgot the disclosure slide. I do get royalties from NuVasive and from Zimmer Biomet, and it's got nothing to do with this talk. So this patient presents with right supraspinatus fossa pain and right thumb pain and numbness, and right biceps mild weakness, 4+ out of 5. So most people know that this is going to be sort of a C6 radiculopathy. And let's just say that there's an EMG that's positive for a C6 radiculopathy. Patient presents and you get this MRI. That's why I said it's better to look at it on. So it's hard to see all of this, but this is every single axial slide on this patient. And what you see is right here, an annular tear with a small disc herniation at this level, and the topogram says it is at this is 2-3 at C3-4. And then let's look at the topogram for C5-6, 2, 3, 3, 4, 4, 5, 6. This is C5-6 right here, and no, I'm sorry, this is C5-6 here. It's totally clean. Don't see anything. So anyone want to hazard a guess? Just shout it out if you think that you should operate at C3-4, or you should operate at C5-6, or something else. Anyone want to hazard a guess as to what's going on here?
5-6. They co-located the two series wrong.
Exactly. How did you guess that?
Because I see it all the time. They're
Yep.
like, that's not C5-6, or like that's at C. Yeah, so
it's exactly right. So if you take a look at this topogram here, look at this. This is supposed to be C2-3, and it's at the top of the dens. So all you have to do is look at their top level and their bottom level, and you also see the morphology. This is not a C6-7 morphology or a C5-6 morphology. It's got transverse processes. This, on the other hand, is definitely not a C5-6 morphology. And if you take a look down at the C3-4 level, this is not a C3-4 morphology either. And I see one or two of these every single year. So don't trust the topograms that they give you. This one says that it's a C5-6, and you got transverse processes. You can see the one that we were looking at, they say it's C3-4. There's no way that this is C3-4. And there's no way this looks like the top of C5-6. You see the elongated transverse processes. This is C6-7. Classic for C6-7. And there's another example of this. You look at this one and you say, okay, the problem here is you've got a herniated disc on the right side. It's kind of broad-based. That's at C5-6. So if you don't think and you don't look carefully at this and you end up looking at this, you're going to operate at the C5-6 level when in fact, look at this topogram up here, locates over here. C2-3, they say, is up here, not over here. And so if you count down, you say, oh, this is the C5-6 level. But again, you see the elongated transverse processes. So what levels are these? This one, and this one. Well, if you listen carefully to what I've said so far, you see that the elongated spinous processes, this is the morphology of a C6-7 level. You see the large bifid spinous process. This is C2-3. And this is obviously a C7T1 because you see the huge transverse processes here, and you're going to put a pedicle screw down here into the pedicle of T1. You need to be able to look at this and instantly recognize that this is C2-3, this is C6-7, and this is C7T1. Always count from bottom up and from top down, from C2 on down and up. Sometimes they change the gantry on you. They start cutting it in one way, and then because the cervical spine is lordotic, they start cutting it a different gantry. And if you don't know that and you're just looking at the levels, you're going to miss that. So you need to understand the morphology. This is clearly in the upper cervical spine, mid cervical spine, and this is C7, C6-7 right there. That's what C6-7 looks like. And you need to be aware of that. Look at the vertebrae. And every time you look at an MRI, familiarize yourself with what a C6-7 looks like, which is this. This is the upper cervical spine, and this is now getting the thoracic spine. That way, you'll never make that mistake. Believe it or not, in this case, the neuroradiologist called this as a C3-4 herniated disc with an annular tear, the neuroradiologist. So you can't trust the neuroradiologist to get that right for you. And same thing here, the neuroradiologist. So these were cases from 2 separate years. Okay, now let's take a look at this CT scan and say, let's look at these axial images and say, what looks bad in this person? Well, let's see. C2-3 doesn't look bad here. C3-4, maybe a little bit here. C4-5, maybe a little bit here. C5-6, maybe a little bit here on the left side. Otherwise, not too bad. Neuroradiologist read everything as being little to no mild foraminal narrowing. Well, take a look at what they're seeing and what I look at. So they get a cut here and they see a little bit of narrowing, but they say, well, that may be in a different part of this. When you take a look at an oblique sagittal image, you will see the true diameter of that foramen. And let me show you a couple of images what I'm talking about. So on this oblique sagittal MRI, CT scan, you can see there's narrowing. You cannot see it just by looking at, when you look at this axial, you go, oh, that looks pretty wide. And when you take a look at this axial images, you see that any nerve root that's going to be in here is going to be tight. The nerve root's going to be tight here, and it's going to be wide open here. And why do you get that? You get that because an axial image that is obtained above the spur is going to look wide open and normal. If you go in between the spurs right here, if that axial image happens to be cut there, it's going to look wide open and totally normal. And if you cut below that spur, you're going to sit there and think, well, everyone's going to look abnormal down here because it's going to be in the narrowest part of the foramen and it's going to be tight, which is why the neuroradiologist said there's no foraminal stenosis on the left side of C3-4. Now, why is that important? It's important because the insurance companies take a look at what the neuroradiologist says and says there is no minimal neuroforaminal narrowing on the left side at this level. And so if you say the patient has a high cervical radiculopathy and clear-cut C4 radiculopathy, the insurance company is going to deny you doing surgery at that level. Only by doing oblique sagittal images, which now everybody at Cornell and Columbia, all the neuroradiologists do this. I asked them specifically on every CT, every MRI, I want you to get oblique sagittal images and read it on that, because this is the diameter that matters. I'll show you what I mean. So if you take a look at this image, you see the large spur that's coming out here, but a cut above it is going to show absolutely nothing on that axial images. And you won't be able to tell on this that there is narrowing in this foramen. Only by seeing this image can you see that. And again, above and below. So when you get a sagittal image that's like this, it is cutting straight down here. That's why it looks absolutely normal, because there is an infinite amount of space between the facet joint and the anterior part. As you get here, now you're seeing a foramen that is this wide, going from here to here. And as you come here, everything's going to be normal. But that's not how the nerve root travels. The nerve root doesn't sit from here to here. It sits from here to here. That's why you have to look at an oblique image. So this is a 52-year-old spine surgeon, had left 5- out of 5 deltoid, 4 out of 5 biceps, pain in the shoulder, biceps. EMG showed a C5, C6 radiculopathy. So this was the MRI. So his partner or spine surgeon goes in, does a posterior foraminotomy at C5, 6. You can see some of the post-op. Does a foraminal decompression. Patient wakes up with a deltoid palsy and profound deltoid weakness now that he didn't have before. His biceps got a little bit better, and they get repeat studies. They get repeat EMG, nerve conduction. So it says he's got a C5, 6 radiculopathy, and now he's got profound weakness. Actually, his biceps actually got worse also. Pain's no better, and EMG again shows C5, C6 radiculopathy. They get a repeat MRI, and they're looking at it, and they said, everything looks totally normal. We don't know what's going on. And so the surgeon sends the MRI to the fellowship director. The fellowship director takes a look at it and says, it looks like you did a pretty good job. I mean, maybe he just dinged his C5, or you pulled too hard on his shoulders. And he sends me the MRI image, and this is the MRI image. And this was now many years ago, probably about 7 or 8 years ago by now already. So what's going on with this guy? Anybody have any idea? Profound deltoid weakness. Well, I'll tell you. So you have 3 spine surgeons. The guy who was the fellowship director, the spine surgeon who was the patient, and the spine surgeon who operated on the patient. They're all concentrating at the C5, 6 level. And the neuroradiologist reads the C4, 5 level as being totally normal, and the C3, 4 level as being a little bit narrowed. Well, there are a couple of things that could be going on. Number one, he could have a prefixed brachial plexus, and the C4 nerve root here could be contributing to his deltoid. But even more importantly, he has a herniated disc in the foramen at C4, 5 on the left side, which a well-hydrated disc often hides itself. But you can tell the difference between the left side here and the right side here. There is something here. And you got to look at the oblique sagittal images to see that there's a herniation out here. Sometimes even a T1 weighted image shows you the foramen even better than this. Yes, he had something here, but he clearly has something. So I suggested go back in, take out the C4, 5, do an ACDF, and he'll get better. They did, and he did. So the moral of the story is, don't rely on the neuroradiologists. They're very good at what they do. I'm not saying that they're bad. I'm just saying that you got to be better. I'm just saying that they will miss a lot of things. Why? Because they don't know any clinical history, and they got to look at the thyroid gland. They got to look at the soft tissues of the neck. They got to look at everything. Whereas you're looking for the C4, 5 level and maybe the C3, 4 level. Okay, then I'm going to show you a couple cases of recurrent myelopathy. 2 years post-op, this patient develops myelopathy. And first case, cases 2, 3, and 4, patients were found to have worsening myelopathy with no compression on the MRI. This patient is 10 years post-op. This patient is 2 years status post C3 to 7 fusion, laminectomy and fusion this patient had. This patient is 10 years post-op, and they are getting worsening myelopathy. Everything else has been ruled out, and they don't know what's going on. So this is a case out of Nebraska. Why are they myelopathic when their MRI looks fine? So a number of surgeons look at them and they say, oh, there's nothing wrong with them. Well, this person has recurrent myelopathy because they've got a stretch myelopathy. This is with them lying down, but you notice when they're standing up, they are kyphotic, and they're stretching their cord over that kyphotic segment, and they have a stretch myelopathy. You can see what happens to them when you stand them up and put them in the same position that they're in. The soft tissues compress them from behind, and their cord, which looks perfectly fine here, they're not living their life lying in a supine position. They're living their life walking around like this, and the cord is constantly being stretched across there, and the soft tissues are bowing in and compressing the cord here. That's why I don't like doing laminectomies, and I prefer laminoplasties, because the hard part of the lamina prevents this compression. So why are these people myelopathic? Well, this one on extension, the soft tissues bow in and cause severe compression. You can see on an extension MRI what happens to them, squashed. And you can see why they get a cord signal change despite a static MRI showing everything to be normal. How about this patient? They're instrumented. They have screws and rods here, and yet the soft tissues can still bow in and cause severe compression of the cord. For this patient, I recommended that they put a crosslink across so that the crosslink would act as the hard stop to the soft tissues. And same thing with this patient. Post-laminectomy, either on flexion or extension, you can still get compression. So if you had somebody who looks like they got a great decompression and they're presenting with myelopathic signs or symptoms, make sure you get flexion and extension MRIs, and that'll tell you that what'll happen. And John McClellan is the spine surgeon who found all of these, and we wrote up a case report and published it back in 2013, showing the importance of flexion extension MRIs when you don't know what's going on, when it's a mystery. Now, how about this? You do an ACDF on somebody and they have recurrent pain. Patient presents with, let's say you had the ACDF, and let's say that your fellowship director did the ACDF on you, or your best friend, or somebody you highly respect. And afterwards, you get constant severe pain. And you go back to that surgeon, the surgeon says, there's nothing wrong. Everything looks good. Your MRI looks clean. Your CAT scan looks good. You're solidly fused on x-rays. What do? Do you say, one, oh gosh, the guy I went to is the tops in his field. So it's obviously in my head, I need to see a psychiatrist. I'm just going to forget about the pain, the weakness, and the numbness? Or would you think about getting another opinion? And if it's you and you're not a spine surgeon, let's say you're an ENT doctor, would you just say it's in my head and forget it? Or would you go and get another opinion? Obviously, you're not going to think that you're crazy. You're going to go get another opinion. And yet spine surgeons tell patients all the time, or basically imply that you're crazy. If there's nothing wrong with you, you should just forget it and go see a psychiatrist. We say that all the time, and we should not. Why? Because most of the time when the patient complains of the same pain they had before the ACDF, it went away after the surgery and it came back. My nurse knows that the diagnosis is a pseudoarthrosis, even without looking at the x-rays, examining the patient, because that is the number 1, number 2, and number 3 most likely diagnoses. So how do you diagnose a pseudoarthrosis? Do you look at bridging bone plus flexion extension, or all of those with a CT scan? Well, on a static image at 1 year post-op, you can tell, or 2 years, if the bone is remodeled, you can tell that they are fused. However, flexion extension views are the best. This patient presents ACDF did well for 6 months and then started having recurrent symptoms. So the surgeon said, there's no motion there. You're solidly fused. There's nothing wrong with you. And he got an MRI and he said, you know what? Every level looks fine. So the patient goes to another surgeon looks at it and goes, yeah, did a great job. There's nothing, there's no foraminal stenosis. The CAT scan, the radiologist and 2 spine surgeons all say, yeah, you got bone growing right through there. It looks great. You got both levels are solidly fused. I see all the bone growing through there. There's nothing wrong. Basically made the patient feel like they were making it up for whatever secondary gain. But when you closely look at the x-rays by zooming up on them and actually measure the interspinous process distance, as I did when she presented to me, I noticed there was 3 millimeters of motion at the top level. And at the bottom level, there was 2.2 millimeters of interspinous process motion. And I zoomed it up even further. And I noticed that when they extended, there was a gap between the prosthesis and the bone. And when they flexed, it disappeared. There's clearly motion. There's a gap here, a gap here, a gap here, gap here, and here. I said, you have a non-union. I fixed her posteriorly. All of the symptoms resolved. Patient was very, very happy and wondered why the other 2 spine surgeons couldn't figure this out and why the neuroradiologist missed all of that. Well, they missed it because they didn't use proper criteria. They just looked at it and eyeballed it. And when you eyeball this, you go, yeah, it looks like it's not moving. I don't see much motion between here and here. But the eyeball is not very good at detecting 1 or 2 millimeters of interspinous process motion on a non-magnified image. So we published this paper that said that you got to look at the interspinous process. You have to magnify this image as much as possible. They've got to move at least 4 millimeters at a non-fused level to show that they've done a good job. And then it's got to move less than a millimeter if they're fused. And on the CT scan, you can't look at what's going on inside the graft. You have to look at extra graft bridging bone. If there's no new bone formation where you didn't put it, like in the sides or behind, it's got a pseudoarthrosis. So this one shows a pseudoarthrosis, and we published these 2 papers on the dynamic plane radiographic criteria and the CT criteria for assessing fusion. Look for extra graft bridging bone. This is one of my favorite operations because the results are often better than the original ACDF because patients have been suffering for so long and their original surgeon has made them feel like they're malingers or crazy. Like this orthopedic surgeon, after she had her revision operation. So she has an operation. I initially chose a local surgeon who I believed to be competent to do what I thought was a relatively simple single level surgery. I had a very poor outcome. She felt great afterwards. The pain came back. It was the same pain. After being gaslit for months and being made to feel crazy, even as a surgeon, I found Dr. Riew, who has literally changed my life. I fixed her pseudoarthrosis, took away the pain, and she said, I can't believe this guy made me feel like I was crazy. She moves more than a millimeter here. And it's hard to see when you just eyeball it. On the CT scan, there's no extra cage bridging bone. There's no bone here. There's no bone back here. There's no bone here. And she moves on flexion extension. Very simple. You go in the back, put 2 screws in, put a rod in there. Pseudoarthrosis is fixed. She's very happy. And then she posts a nice Google review about you as opposed to posting bad Google reviews about the first surgeon. So the moral of the story is you got to be to be a good spine surgeon, you have to be a phenomenal neuroradiologist. If you can't see it, you can't fix it. So you got to be able to see it in order to fix it. And so before you even pick up the knife, you got to make the diagnosis. That's it. Thank you.
Thank you, Dan. That was awesome to get your insight and kind of thought process. I've seen it firsthand, and it's definitely real to look at those images and kind of see what others have missed. And something I've talked to you about is that we don't have the ability to kind of look at those parasagittal cuts, and it's probably like that in many different hospitals and places across the country. So just added tools to your toolbox.
Well, you can in most of the PACS systems, they allow you to manipulate things in 3D. So even images that patients upload from other institutions, I take a look at it. But if you don't have that on your packs, you got to talk to a neuroradiologist and say, this has got to be done. And you can show them an example of why it needs to be done, because otherwise you're going to miss things all the time. And so, Stephen, that I make all the fellows now upload all the images and all the relevant images and everything else, and I put that in my office notes. The number of insurance peer-to-peer things that I've had to do have dropped down to, instead of being like once a week, it's now once every 6 or 7 weeks. It's very rare because I just put the relevant image. I say, neuroradiologist missed the oblique sagittal image showing a foraminal disc herniation or a foraminal spur. I show it right there. And the guy who's doing it at the other end says, I'm not really supposed to look at the images, but I can't help it because you got it right in your note. And I agree with you. The patient does have foraminal stenosis there. And so I'm approving that level. And so that's why I cut and paste the relevant images. If the neuroradiologist read something as being normal, I make sure that that's the case. And that's why I make all the fellows read all the MRIs and put that in, and then I edit it. It takes a long time to do that, but that's the only way I know that the fellows are learning how to read the neuroradiology studies. And unfortunately, I only started doing that in your year. And the guys who trained with me before then, I think I let out without giving them good training in neuroradiology.
Dan, John Hurlburt, University of Arizona. Great talk. Thank you. Hey, I just wanted to add on to your experience. Since I came to Arizona, I think the most common revision surgery I do in the cervical spine is the 0P plates, the integral cages. And I guess they're an easy thing to put in, but they have a high non-union rate. So it was interesting to kind of see your experience in that too.
Yeah.
And they subside very, very frequently. Yeah.
It works if you put BMP into them and you put them up high, or if you do a front back. But if you're going to put a 0P in at C6-7 or as part of a 3-level ACDF, that bottom level is never going to heal. And so I think they work at C2-3, C3-4, C4-5, or down lower if you do a front back, or if you mobilize them to hard collar, and if you use BMP. But otherwise, they don't have a lot of room inside of them to put bone graft that's going to heal.
Dr. Riew, I've seen some data recently that suggests a significant portion of folks that have like an interspinous motion of 2 millimeters at 12 months might go on to fuse at 18 months or 24 months. How do you think about that? I mean, do you tell folks to maybe wait it out for another 6 months, or if they're symptomatic at a year, do you go ahead and do a revision?
No, I basically tell them this, that our data, when we looked at single level ACDF, that was in the arthroplasty versus ACDF trial for Prestige and Bryan. And what we found was that 6 months after single level ACDF done by some of the best spine surgeons in the United States, only 60% were healed at 6 months, 80% at 1 year, 90% at 2 years, and around 93% at 5 years. So I tell them, if you're not healed at 1 year, there's a 50% chance you'll be healed by 2 years. If you're not healed at 2 years, it will take another 3 years before you get the next 50%. Pseudoarthrosis is not dangerous. We fix it when you say, I can't stand the pain, I got to get it fixed. Or if they did an inadequate decompression, or you're having numbness or weakness that's profound. And then I fix it. But I've got a little blurb on my Epic that says pseudoarthrosis, not dangerous. We don't have to fix it. We fix it when you want to fix, yada, yada, yada. So, but a lot of people think that the single level ACDFs heal very quickly, and a lot of people are deluding themselves. So just look for those patients, as John said, look for those patients who have a pseudo, because you're the hero. If you can be your own hero by having your pseudoarthrosis and then you diagnose it and you fix it, or that person can go to 5 other spine surgeons telling them how lousy a surgeon you are. So rather than having that person advertise to their neurologist, physiatrist, their internist, every one of their friends, because what would you do if you were a surgeon and you went to another surgeon and they fixed you and you got better for a while and you got worse again? Would you keep it to yourself and keep it hidden to yourself? You go back to the surgeon and the guy says, there's nothing wrong with you. There's nothing more I can do for you. Would you say, he's right, I must be an idiot, I'm going to live with my pain? No, you get other opinions. So don't let your patient go advertising how lousy a surgeon you are. Fix your own mistakes, and then you'll be happier.
Awesome. Well, it's 7:01. If we don't have any more questions for Dr. Riew, we'll close it here. Dr. Riew, thank you so much for joining us. Definitely a topic that's very, very helpful for our fellows. You've inspired me to shoot off an email to our neuroradiologist about oblique shots on MRI, something Bob and I have argued about for years now, and we need to kind of get that done. So everybody have a great weekend. Thanks again, Dr. Riew, and stay safe.
Superb as always, Dan. Thanks.
Thank you, Dan. Nice seeing you.
Good to see you, Baruz.